Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here for this one. It is a big topic.
It really is. We approach surgical intervention with a mindset that is fundamentally rooted in mechanical precision. It operates on this framework of, physical engineering.
Right. Very structural.
Exactly. You receive a patient in the trauma bay presenting with, say, a grade 4 splenic laceration alongside a hemodynamically unstable pelvic ring fracture.
Classic disaster scenario.
Right. And the algorithms are just drilled into us from day one. You pack, you embolize, you fix the broken plumbing.
Yeah, you stop the bleeding.
And the underlying assumption governing that damage control laparotomy is that once the gross anatomical integrity is restored, and hemorrhage is arrested, the physiological recovery just naturally follows.
Which is such a comforting thought, right? The operative phase really lulls us into this false sense of a binary outcome.
Oh, completely.
You definitively stop the bleeding, you restore macrovascular perfusion, and, the immediate mechanical crisis is neutralized. That immediate gratification of source control in the OR provides a really deceptive sense of finality.
But that sense of finality just evaporates the moment you hand off that patient in the surgical intensive care unit.
It really does.
Because the mechanical precision completely falls apart at that point. You are no longer dealing with gross anatomy. You are looking at a biological landscape that is, frankly, infinitely more opaque.
Muddy waters.
Exactly. The visible injuries are repaired, the drains are placed, the hemodynamics appear stabilized on pressors, but the patient just continues this relentless microscopic decline.
Yeah, it represents the absolute definition of diagnostic and therapeutic muddy waters. For the trauma and surgical critical care surgeon, this systemic deterioration remains the ultimate adversary.
The big boss at the end of the level.
Exactly. We are talking, of course, about multiple organ failure, or MOF. However, the critical paradigm shift we must recognize today, and this is so important for the listener to grasp, is that this adversary has fundamentally mutated.
Right.
The clinical manifestation of MOF you are treating on rounds this morning is not the MOF the previous generation of attendings treated 30 years ago.
And that biological evolution is the core mission of today's deep dive. We are examining Frederick A. Moore's seminal chapter, The Evolving Epidemiology and Pathobiology of Multiple Organ Failure.
A phenomenal piece of literature.
It really is. We are going to explore how decades of critical care advancements, the very protocols and evidence-based guidelines that have made modern trauma surgeons so incredibly effective at rescuing patients from immediate exsanguination, how those have inadvertently forced MOF to evolve.
Yeah, it evolved from an early, rapid, fatal outcome into this lingering, devastating trajectory that we now know as chronic critical illness, or CCI.
So we are going to extensively unpack the clinical data and the underlying molecular pathobiology of what the literature now defines as PICS.
Right, the persistent inflammation, immunosuppression, and catabolism syndrome.
Exactly, PICS. More importantly, we are going to look beyond the standard inflammatory markers. We want to focus exactly on what is happening at the cellular level within the bone marrow of your SICU patients.
The bone marrow is the key to all of this.
It really is. We're going to see the specific mechanisms locking them into this highly lethal catabolic phenotype. But to understand the modern PICS phenotype, I think we have to trace the epidemiological shifts in our own surgical ICU advancements over the last 50 years,
We have to look at how each intervention forced a compensatory evolution in the pathology.
Right. So looking at the surgical landscape of the 1970s, ICUs were just beginning to standardize mechanical ventilation and aggressive monitoring.
Which allowed patients to finally survive initial single-organ insults.
Yeah, exactly. And MOF was primarily recognized as the fatal terminal expression of uncontrolled infection. In that era, we're looking mostly at massive intra-abdominal sepsis following penetrating trauma or delayed emergency general surgery.
And the clinical reality of that era was just grim. ICU mortality for established MOF in the 1970s consistently exceeded 80%.
Wow, over 80%.
Yeah. The prevailing surgical philosophy was highly source control oriented. This was driven by the advent of earlier generation CT scanners and the birth of percutaneous interventional radiology.
So their algorithm was pretty straightforward then.
Very straightforward. Utilize the new imaging to localize the fluid collection, deploy broad-spectrum antibiotics, and perform aggressive, definitive operations to establish drainage. drain the pus,
Yeah,
essentially.
the old surgical adage.
Exactly. The physiological assumption was that eradicating the nidus of infection would independently resolve the progressive organ failure.
Except, the clinical observation directly contradicted that assumption. I mean, even when aggressive laparotomies achieved pristine source control and the abdomen was thoroughly washed out, patients remained trapped in profound hypermetabolism.
Yeah, they just kept burning energy.
Surgeons were documenting resting energy expenditures far exceeding baseline, and this was accompanied by massive, visible depletion of lean body mass.
Despite attempts at caloric supplementation.
Right. They were watching patients literally melt away in the bed, which led to the incredibly descriptive term septic autocannibalism.
That direct observation of relentless catabolism precipitated a massive pivot in the late 70s and early 80s. The field moved toward highly aggressive nutritional interventions.
Because total parenteral nutrition had just become commercially viable, right?
Exactly. TPN was now widely accessible. The surgical research community hypothesized that if the body was aggressively consuming its own somatic protein stores to fuel the inflammatory response, well, the solution was simply to outpace the catabolism with intravenous caloric loading.
Just feed them through the vein until they stop breaking down muscle.
That was the idea. They formulated these stress formula TPNs. They heavily enriched them with specific amino acids like arginine, glutamine, and branched-chain amino acids. The goal was to force the critically ill patient into an early, definitive, positive nitrogen balance.
Okay, let's unpack this. Because the attempt to biologically force a positive nitrogen balance in a hypermetabolic state through isolated IV supplementation, it fundamentally ignores the underlying cellular signaling.
It completely ignores it.
You cannot simply push substrate into a system where the anabolic receptors are completely downregulated by systemic inflammation. I always think of it like it's like trying to rebuild a collapsed building while the fire is still actively burning simply by dumping more bricks onto the site.
That is a highly accurate assessment. And it explains why the widespread implementation of those stress formula TPNs completely failed to alter the MOF mortality curve.
It did nothing for mortality.
Nothing. In fact, the pivotal clinical trials of the 1980s convincingly demonstrated that early enteral nutrition, or EEN, was vastly superior to early TPN.
And not because of caloric density, right?
No, not at all.
Yeah.
It was because EEN significantly reduced nosocomial infection rates. This clinical finding necessitated a massive shift in our understanding of MOF pathophysiology, particularly regarding the role of the gastrointestinal tract.
Because the prevailing theory had positioned the gut as the primary motor of early MOF via bacterial translocation.
Right, the gut origin hypothesis.
Yeah. The hypothesis relied heavily on rodent models. They suggested that splanchnic ischemia compromised the mucosal barrier, which then allowed viable enteric bacteria and endotoxin to directly seed the portal circulation and prime the Kupffer cells in the liver.
The rodent models of bacterial translocation were very elegant. But subsequent translational human studies, specifically ones utilizing portal vein sampling in trauma patients, they seriously challenged its clinical relevance as an immediate primary driver of early MOF.
So what did the superiority of early enteral nutrition actually illuminate, if not stopping translocation?
It illuminated a completely different mechanism. Providing enteral substrate wasn't just about delivering calories. It was actively maintaining gut-associated mucosal immunity.
Oh, interesting.
Yeah. It sustained secretory IgA levels and mechanically supported the gut-associated lymphoid tissue, the GALT. By preserving local mucosal immunity, EEN blunted the systemic inflammatory response.
Which effectively disproved the dogma that early massive bacterial translocation was the initial trigger.
Exactly. Gross bacterial translocation is now understood as a terminal, late-stage pathologic event. You only see it in patients already suffering from profound, irreversible gut disuse and mucosal atrophy.
Which perfectly bridges into the conceptual leap of the mid-1980s. The surgical community began documenting identical patterns of progressive organ dysfunction in patients who sustained massive blunt trauma, but without any identifiable infectious source.
Sterile inflammation.
Exactly. A patient arriving with a crushed pelvis, bilateral femur fractures, and severe pulmonary contusions. They present with a sterile bloodstream and zero evidence of pus, but they would reliably develop the exact same clinical sepsis syndrome as the patient with the perforated viscus.
And recognizing that severe non-infectious insults could perfectly mimic massive bacterial infection, that birthed the concept of the systemic cytokine storm.
It's a phrase we hear all the time now.
Yeah, and it moved the field toward the two-hit model of MOF.
So hit number one is the massive primary mechanical insult that primes the innate immune system.
Right. The patient is then highly vulnerable to a secondary, often iatrogenic, lesser insult.
Hit number two.
Exactly. This could be a transient episode of hypoxia, maybe a secondary orthopedic intervention, or, most commonly, the whole body ischemia reperfusion injury resulting from an episode of hypovolemic shock.
So the ischemia reperfusion injury serves as hit number two. That activates the primed systemic PMNs and triggers widespread endothelial cell injury.
It shreds the endothelium.
But the molecular explanation for why sterile crushed tissue perfectly mimics an infectious pathogen didn't fully materialize until the danger hypothesis emerged in the 90s.
The danger hypothesis was revolutionary.
It really was. We are all well-versed in how pattern recognition receptors, specifically toll-like receptors, identify exogenous Ps like endotoxin or flagellin to trigger innate immunity. But the danger hypothesis revealed that our own endogenous intracellular contents utilize those exact same pathways when released outside the cell membrane.
Yeah, when tissue is crushed or subjected to profound ischemia, those cells bypass programmed apoptosis. They undergo uncontrolled necrosis or pyroptosis. They violently rupture and dump their intracellular contents directly into the systemic circulation.
These endogenous compounds are DAMPs, right? Damage-associated molecular patterns.
Exactly. They include HMGB1, S100A proteins, heat shock proteins, and notably massive quantities of mitochondrial DNA.
And rather than relying on basic analogies, I think we have to view this through the lens of evolutionary biology and cellular systems. The innate immune system operates like a hardwired, non-negotiable software algorithm.
It doesn't think, it just reacts.
Right. And evolutionary theory suggests mitochondria are essentially ancient engulfed alpha proteobacteria.
Yes.
So when a massive crush injury shears skeletal muscle and dumps mitochondrial DNA into the central circulation, the toll-like receptor 9 binding sites don't perceive crushed muscle.
No, the receptor literally reads unmethylated CpG motifs characteristic of bacterial DNA.
Exactly. The systemic algorithm triggers a massive, overwhelming inflammatory cascade because the receptors literally cannot differentiate between a sterile structural collapse of tissue and a hostile massive bacterial breach.
What's fascinating here is how the discovery of that mechanism directly influenced our clinical behavior. Recognizing the two-hit model and the destructive potential of ischemia reperfusion injury compelled trauma surgeons to radically alter their early resuscitation strategies.
Because the absolute priority shifted to aggressively preventing that second hit.
Right, by rapidly correcting the oxygen debt. But, and this is big but, that aggressive pursuit of perfusion accidentally engineered entirely new, massive iatrogenic epidemics in both the trauma bay and the SICU.
And the first of those being the era of supernormal oxygen delivery, which was championed by William Shoemaker.
Shoemaker's hypothesis.
Yeah, and the physiological rationale was actually really sound on paper. Shoemaker observed that trauma patients who ultimately succumbed to MOF consistently failed to mount a hyperdynamic cardiovascular response during their initial resuscitation.
They exhibited persistent low systemic oxygen consumption, or VO2.
Right. So he hypothesized that this occult, flow-dependent tissue hypoxia was the primary trigger for the release of DAMPs and subsequent non-infectious MUF.
And the clinical application of that hypothesis completely defined the era of the pulmonary artery catheter.
Oh, the Swan-Ganz era.
The standard protocol mandated floating of Swan-Ganz in virtually every high-risk trauma patient. You'd calculate their baseline hemodynamics and then aggressively push crystalloids, blood products, and high-dose inotropes,
Just whipping the heart.
pushing it to the max. The goal was to artificially force their cardiac index and DO2 to supernormal levels, theoretically satisfying the massive occult oxygen debt of the crushed tissues.
But driving the myocardium with high-dose dobutamine while simultaneously volume loading a patient with massive endothelial leak was fundamentally flawed, right?
Deeply flawed. The prospective trials eventually proved that intentionally driving supernormal DO2 not only failed to improve mortality, but often exacerbated cardiac morbidity.
But tracking the data from those massive resuscitation protocols inadvertently exposed an entirely separate physiological threat regarding the fluids we were using, specifically the packed red blood cells.
This is where it gets really dark. When investigators analyzed the multivariate logistic regression models for early MOF, the severity of initial shock, quantified by profound base deficits and lactic acidosis, was an obvious predictor. But the most robust, consistent, and independent predictor of early MOF was the volume of blood transfused.
The volume itself was the predictor.
Exactly. Specifically, receiving greater than 6 units of PRBCs within the first 12 hours post-injury correlated directly with an exponential rise in organ failure.
Now, for any trauma surgeon managing a ruptured spleen and a shattered pelvis, transfusing 6 units of PRBCs in 12 hours is a standard, almost routine, massive transfusion protocol.
It happens every night in the Level 1 center.
Yeah. The idea that the primary vehicle for oxygen delivery was acting as an independent variable for systemic organ failure forced a deep dive into the biochemistry of stored blood. We know it comes down to the storage lesion.
Right, during refrigerated PRBC storage, the erythrocytes undergo progressive morphological and biochemical degradation. The degradation of the red cell membrane generates highly active pro-inflammatory lipids, most notably platelet activating factor, or PAF, alongside other lysophospholipid.
So when you rapidly transfuse these accumulated lipid mediators into a trauma patient during a massive hemorrhage protocol, they serve as incredibly potent priming agents.
They systemically prime the patient's circulating PMNs.
So the moment those primed PMNs encounter any secondary stimulus like, the ischemia reperfusion generated when you finally restore their blood pressure, they undergo massive degranulation.
It's just dumping their contents.
Right, releasing massive quantities of superoxide radicals and elastase that essentially shred the patient's own pulmonary and systemic endothelial beds. You are actively transfusing a chemical weapon against their own vasculature.
Which is a terrifying realization.
Yeah.
Washing the PRBCs to remove the supernatant lipids was proposed, but logistically, attempting to wash blood during an active MTP in a crashing patient, it's impossible.
That specific logistical impossibility catalyzed the massive industry-wide push to develop a hemoglobin-based oxygen carrier, or HBOC.
The holy grail of trauma resuscitation at the time.
Right. The goal was to isolate the oxygen-carrying capacity of hemoglobin without the inflammatory lipid baggage of the intact erythrocyte membrane. And this effort culminated in the polyheme trial.
Polyheme was a fascinating chapter. It was a human polymerized hemoglobin solution that, in vivo, completely avoided the transfusion-induced PMN priming scene with stored blood.
And the scope of the polyheme trial was absolutely unprecedented. It was a massive, multi-institutional phase 3 clinical trial executed under the FDA's exemption from informed consent, or EFE.
Which allowed administration in the pre-hospital setting by EMS personnel during the critical golden hour.
And the primary efficacy endpoint was actually met, wasn't it?
It was. Patients resuscitated with polyheme, which spared them from receiving stored blood for up to 6 units in the first 12 hours, demonstrated survival outcomes comparable to the standard of care. It successfully proved the physiological concept that an HBOC could maintain vital organ perfusion when banked blood was unavailable.
Yet, HBOCs are noticeably absent from our massive transfusion protocols today. I mean, the efficacy was there, but the biochemical reality of cell-free hemoglobin just derailed the FDA approval process.
Yeah, the critical failure lay in the adverse event profile, specifically a statistically significant increase in myocardial infarctions.
Why did that happen?
When hemoglobin is no longer encapsulated within a red blood cell membrane, the free tetramers rapidly scavenged nitric oxide from the surrounding vascular endothelium.
And nitric oxide is the primary endogenous vasodilator.
Exactly. Depleting it caused profound, uncontrolled systemic and coronary vasoconstriction, leading to ischemic cardiac events.
So deprived of a viable HBOC, we remain reliant on blood, but more problematically in the 90s, we remain reliant on massive volumes of crystalloid.
Oh, the crystalloid days.
Yeah. The universal adoption of ATLS guidelines and the standardization of damage control surgery meant patients who previously exsanguinated in the field were now surviving the initial phase. But the combination of delayed definitive hemostasis, aggressive ATLS crystalloid protocols, and the lingering attempts at DO2 optimization culminated in the abdominal compartment syndrome epidemic.
And retrospective analysis clearly defines the ACS epidemic as largely iatrogenic. We were routinely infusing tens of liters of normal saline and lactated ringers.
Tens of liters, it's hard to even imagine now.
The profound capillary leak caused massive third spacing into the bowel wall and the retroperitoneum. The compliance of the abdominal wall was rapidly overcome. The clinical picture was unmistakable: a rigid, distended abdomen, peak airway pressure spiking on the vent to 40 or 50 centimeters of water, and an abrupt cessation of urine output.
Because the massive intra-abdominal pressure mechanically compresses the renal veins and directly compromises renal cortical blood flow.
Exactly. The only salvage maneuver was performing decompressive laparotomies directly in the SICU bed, simply to allow the ventilator to function.
Slitting the fascia open right there in the unit.
Right. But experiencing that epidemic forced a fundamental course correction in U.S. trauma practice. It catalyzed the transition away from crystalloid-heavy regimens toward hemostatic resuscitation.
The 1.1.1 balanced blood product ratios utilizing plasma and platelets from the outset.
Yes, we largely abandoned the Swan-Ganz catheters. We integrated the FAST exam and liberalized whole-body CT to minimize time to definitive hemorrhage control. Consequently, full-blown secondary abdominal compartment syndrome has transitioned from a routine daily occurrence to a relatively rare complication in modern centers.
And having aggressively optimized those resuscitation protocols, the surgical community really believed they had successfully mapped the immunological timeline of the surviving patients.
They felt they had it all figured out.
Yeah, the prevailing dogma of the late 90s and early 2000s was the sequential SIRS, followed by CARS model,
which provided an elegant sequential explanation for the bimodal distribution of MOF observed in databases like the Denver MOF study. In that study, 1/3 of MOF occurred within 72 hours, but the remaining 2/3 peaked around day 7.
So the model hypothesized that the initial insult triggered an overwhelming innate pro-inflammatory cytokine storm, the Systemic Inflammatory Response Syndrome, or SIRS. We attributed early MO and early mortality directly to this hyperinflammatory tissue destruction.
And to explain the late onset MOS, the theory posited a compensatory overcorrection.
Right, the Compensatory Anti-inflammatory Response Syndrome, or CARS.
The theory suggested the body aggressively downregulates the SIRS fire by flooding the system with anti-inflammatory cytokines like IL-4 and IL-10. This paralyzes macrophage antigen presentation, suppresses T-cell proliferation, and forces a Th1 to Th2 phenotypic shift.
So this resulting period of profound immunosuppression supposedly created the vulnerability for late nosocomial infection.
Yes, which subsequently triggered the late onset MOF.
It's a really intuitive, easily digestible concept. It's basically a systemic teeter-totter. The immune system swings violently into hyperinflammation, and then
the pendulum swings violently back into profound immunosuppression.
Exactly. But the ultimate test of any pathophysiological model is therapeutic efficacy. And when the pharmaceutical industry invested billions of dollars developing targeted monoclonal antibodies against specific pro-inflammatory mediators like TNF-alpha or IL-1 beta to blunt the SIRS phase,
the clinical trials failed uniformly.
they did not budge the mortality needle at all.
The failure of those targeted biologic therapies forced the realization that examining isolated serum cytokines provided an incredibly narrow, highly distorted view of the immune system.
We were looking at a tiny piece of the puzzle.
Right. The true paradigm shift arrived with the inflammation and the host response to injury, glue grant. The glue grant abandoned isolated cytokine assays and utilized high-throughput microarray technology to examine the entire leukocyte transcriptome.
They continuously mapped the real-time expression of the entire human genome following severe blunt trauma.
And the transcriptomic data from the glue grant completely dismantled the sequential SIRS and CARS teeter-totter. They identified what they termed a genomic storm.
The genomic storm.
They documented the altered expression of greater than 75% of the entire human genome. But the critical revelation was the temporal relationship. The activation of the genome was not sequential. There was no distinct SIRS phase followed days later by a CARS phase.
So they happen at the same time.
The genomic storm demonstrated a massive, simultaneous activation of both pro-inflammatory SIRS genes and anti-inflammatory CARS pathways immediately following the injury. The innate immune system was aggressively upregulating inflammatory mediators at the exact same moment the adaptive immune system was deploying profound immunosuppressive signals.
Furthermore, the glue grant data established that clinical recovery directly correlated with the rapid return of gene expression to baseline.
Right. Conversely, the failure to achieve immunologic homeostasis, remaining locked in that state of simultaneous genomic chaos, was the strongest independent predictor for unresolving MOF.
Here's where it gets really interesting, because while the genomic data was redefining the cellular landscape, the clinical landscape of the ICU was being radically transformed by the widespread implementation of evidence-based guidelines, or EBGs.
The protocols took over.
Yeah, the glue grant investigators mandated incredibly strict standard operating procedures for ventilator management, glycemic control, and resuscitation across 8 level 1 trauma centers. Simply enforcing strict compliance with these SOPs over 8 years dropped their in-hospital mortality from 22% down to 11%.
Half. They cut it in half.
And we observed an identical phenomenon in surgical sepsis.
Right. The Surviving Sepsis Campaign, or SSC, Guidelines fundamentally altered the epidemiology of surgical sepsis. The integration of routine sepsis screening tools and computerized clinical decision support algorithms enforcing early aggressive fluid resuscitation and broad-spectrum antibiotic administration, it globally reduced severe sepsis and septic shock hospital mortality from over 35% down to less than 15%.
We effectively eliminated early death from surgical sepsis and early MOF.
But biological systems abhor a vacuum. Because you became so highly proficient at standardizing care and keeping patients alive through the initial mechanical and genomic storm, you inadvertently engineered a new clinical reality.
Because the patients were no longer dying in the first 72 hours, but they also weren't recovering.
No, they were lingering.
A massive new phenotype emerged, chronic critical illness, or CCI.
And this represents the absolute crux of modern surgical critical care. In previous decades, overwhelming MOF resulted in rapid mortality. Today, that early fatal trajectory is exceedingly rare in level 1 centers. However, a highly significant proportion of survivors fail to establish homeostasis. They enter a pathological state characterized by persistent, low-grade organ dysfunction stretching into weeks or months.
To define the underlying molecular pathobiology of this new, lingering state, the Sepsis Critical Illness Research Center, the SIRS at the University of Florida, they coined the term PICS, the persistent inflammation, immunosuppression, and catabolism syndrome.
PICS.
And PICS isn't just a clinical descriptor, right? It's a specific mechanistic framework defining this exact CCI trajectory.
Right. PICS defines a state of ongoing, smoldering systemic inflammation, coupled with profound parallel immune suppression that guarantees recurrent nosocomial infections, all driving a relentless protein catabolism that is entirely resistant to exogenous nutritional support.
Resistant to nutrition.
To validate PICS beyond a theoretical framework, the UF-SERC investigators secured an NIH P50 grant, executing a massive, prospective, longitudinal cohort study to capture the hard statistical reality of this phenotype.
Let's dive deep into that P50 cohort methodology and data because the implications directly impact your daily rounding strategy as a critical care surgeon. They prospectively enrolled 365 surgical ICU patients presenting with severe sepsis or septic shock.
A very robust sample size.
Yeah, and crucially, all these patients were actively managed using strictly embedded surviving sepsis campaign electronic protocols, ensuring the baseline standard of care was optimized. They mapped the patients into 3 distinct clinical trajectories based on their ICU course.
The clinical trajectories were defined with strict temporal cutoffs.
Yeah.
The first group was early death, defined as mortality occurring within 14 days of sepsis onset. The second was rapid recovery, or RAP, capturing patients who achieved full resolution of organ dysfunction and were discharged from the ICU within 14 days.
And the third?
The third trajectory was chronic critical illness, or CCI. This was strictly defined as an ICU length of stay greater than or equal to 14 days with ongoing quantifiable organ dysfunction as measured by their sequential SOFA scores.
Analyzing the demographic and outcome data from Table 1 of that study is just eye-opening. Out of 365 severe sepsis patients, the early death rate was an astonishingly low 4%.
That single statistic validates the effectiveness of modern EBGs.
It really does. And 62% of the cohort fell into the rapid recovery group. But a staggering 34%, more than 1/3 of your fully resuscitated severe sepsis patients progressed into chronic critical illness.
The statistical breakdown of those cohorts reveals highly significant demographic differences, with p-values consistently less than 0.01. The patients who developed CCI were marginally older, predominantly male, and carried a higher burden of baseline comorbidities.
Which makes intuitive sense.
Sure. But more importantly, the initial insult was significantly more severe. A higher percentage of CCI patients presented in overt septic shock, and their admission Apache 2 scores were markedly higher, a median of 22 for the CCI cohort compared to 13 for the RAP group.
We all recognize that an Apache 2 of 22 carries a profoundly high predicted mortality risk. Yet these patients survive the initial phase, only to remain in the ICU for a median of 20 days, compared to just 4 days for the RAP group.
And the severity of their prolonged organ dysfunction, particularly the renal impairment, is a defining characteristic of PICS.
What did the renal data show?
The renal data was striking. 23% of the CCI patients progressed to KDIGO stage 3. Acute kidney injury, requiring renal replacement therapy, compared to only 4% in the RAP cohort.
That's a huge difference.
Massive. This persistent smoldering organ failure is the clinical hallmark of PICS. But the true devastation of the syndrome is not fully captured by ICU metrics alone. It is defined by the catastrophic functional outcomes following discharge.
Right. If we connect this to the bigger picture, the modern critical care surgeon might look at a 4% early mortality rate and define that intervention as a definitive success.
You'd high-five your team.
You would. However, tracking the longitudinal post-discharge data reveals a really grim reality. While the traditional 30-day hospital mortality was low, the long-term mortality curve for CCI patients was relentless. By 12 months post-insult, the mortality rate for the CCI cohort reached an abysmal 40%.
40%.
That is compared to a 6% one-year mortality for the rapid recovery group.
And for the 60% of CCI patients who managed to survive to the one-year mark, the quality of that survival was fundamentally compromised. Nearly 80% of the CCI cohort experienced what the study categorized as a poor discharge disposition.
Meaning they weren't going home?
Exactly. They were not returning to independent living. They were discharged to long-term acute care facilities, skilled nursing facilities, or hospice care.
And the UFSCRC investigators actually quantified that functional decline utilizing validated performance metrics, right?
Yes. They used the Z-Broad Performance Scale, the Eurocol 5D assessing health-related quality of life, and the Short Physical Performance Battery, or SPPB, which objectively measures lower extremity function via parameters like gait speed and repeated chair stands.
And what did the baseline look like?
Prior to admission, the RAP and CCI cohorts exhibited similar baseline functional statuses. However, at 3 months post-discharge, the CCI survivors demonstrated severe, quantifiable disability across all metrics.
Did they ever recover?
No. Crucially, tracking them out to 12 months revealed a complete failure to recover. Their SPPB scores confirmed profound, permanent deficits in basic physical function. They were locked into a state of severe, enduring frailty.
So we have a cohort of patients who survived the initial shock with optimized hemodynamics, yet experience a 40% long-term mortality rate and permanent physical disability.
It's a tragic paradox.
To understand the underlying drivers, the P50 program executed serial biomarker sampling out to 28 days to map the specific pathobiology. Let's dissect the 3 pillars of the syndrome: inflammation, immunosuppression, and catabolism.
So, examining the inflammatory pillar, the blood assays of CCI patients demonstrated a persistent, unresolving systemic inflammatory state. Even 3 to 4 weeks post-insult, they maintained highly elevated serum levels of pro-inflammatory cytokines, specifically IL-6 and IL-8.
And they also looked at DAMPs, didn't they?
Yes, furthermore, they exhibited persistently elevated levels of circulating cell-free DNA. These are the identical DAMPs responsible for the initial innate immune activation. This indicates continuous, low-grade tissue destruction and sustained activation of the toll-like receptors.
Yet, concurrent with this systemic inflammatory state, they're profoundly immunosuppressed, creating the central paradox of PICS.
Precisely. While the innate immune system remains locked in a smoldering state of activation, the adaptive immune system is functionally crippled. The biomarker profiles revealed severe, persistent lymphopenia, a profound quantitative depletion of circulating T cells and B cells.
So they just don't have the cells.
And qualitatively, the remaining lymphocytes are subjected to high levels of soluble PD-L1.
And PD-L1 is an immune checkpoint protein, right?
Correct. When it binds to the PD-1 receptor on the surface of T cells, it induces profound T cell exhaustion and apoptosis. This paralysis of the adaptive immune system is the exact mechanism explaining why CCI patients are continuously vulnerable to recurrent, opportunistic nosocomial infections. They completely lack the targeted cellular immunity required for pathogen clearance.
The third pillar, the relentless catabolism, is perhaps the most clinically frustrating aspect for the intensivist.
It's maddening.
The P50 data utilize 3-methylhistidine urinary excretion as a highly specific biomarker. And 3-MH is an amino acid strictly localized within the contractile proteins of skeletal muscle, specifically actin and myosin. Since it cannot be reutilized for protein synthesis once the muscle fiber is degraded, urinary excretion precisely quantifies skeletal muscle breakdown.
And the data demonstrated persistently elevated urinary 3-MH excretion in CCI patients across the 28-day window. This provided definitive proof that their physiology was actively and aggressively cannibalizing their own somatic muscle mass.
Driven by hormones, mostly.
Yes, this catabolism was driven by a completely deranged hormonal milieu. They exhibited significantly increased levels of GLP-1 alongside profoundly suppressed levels of insulin-like growth factor 1, or IGF-1.
And the suppression of the IGF-1 axis essentially eliminates the cellular signaling required for skeletal muscle anabolism and repair.
Exactly.
So what does this all mean for the critical care surgeon managing these patients? It means you can execute the nutritional protocols flawlessly. You can establish early enteral access, consult your critical care dietitian, and provide perfectly calculated, evidence-based macro and micronutrient support.
You can do everything right.
And despite optimized delivery, the patient's physiology will continue to violently consume its own lean muscle mass. You're basically pouring all this nutrition into a metabolic black hole. The metabolic profile perfectly mimics the intractable cachexia observed in advanced end-stage neoplastic disease.
And the comparison to advanced oncology is not just analogous. It shares identical cellular pathways. To identify the root source of this persistent, paradoxical state of simultaneous inflammation and immunosuppression, the SIRS investigators had to look beyond circulating serum markers and examine the hematopoietic source.
They had to look at the bone marrow.
Yes, they discovered that PICS is ultimately driven by a phenomenon within the bone marrow known as emergency myelopoiesis.
Let's spend considerable time here because understanding emergency myelopoiesis represents the absolute frontier of modern surgical critical care. In a healthy state, the bone marrow maintains a balanced, steady-state production of myeloid and lymphoid lineages. How does a massive traumatic or septic insult alter that architecture?
Emergency myelopoiesis represents a highly conserved, extreme evolutionary response by the bone marrow to a life-threatening systemic insult.
Okay.
When the hematopoietic stem cells detect an overwhelming bacterial invasion or the massive release of DAMPs following severe tissue destruction, the bone marrow essentially panics.
It panics.
It rapidly and violently shifts its entire transcriptomic factory to prioritize the immediate defense mechanism, which is innate immunity. The stem cells are forcefully directed down the common myeloid progenitor cell line, initiating the mass production of myeloid cells to combat the immediate threat.
But because it is an emergency response driven by massive systemic stress signals, the bone marrow doesn't have the time to produce fully mature functional immune cells, right?
Correct. The massive expansion of the myeloid line results in the rapid release of immature myeloid cells into the systemic circulation. These are termed myeloid-derived suppressor cells, or MDSCs.
MDSCs.
Yes. Under normal conditions, these cells would remain in the marrow to fully differentiate into mature functional granulocytes, macrophages, or dendritic cells. The concept of MDSCs is well established in the medical literature, but previously their massive expansion was observed almost exclusively in the context of advanced neoplastic disease.
Like cancer.
Right. Solid tumors actively secrete chemokines that manipulate the bone marrow into producing MDSCs, utilizing them as an immunosuppressive shield against the host's cytotoxic T cells. Identifying this exact same massive, sustained MDSC expansion in trauma and sepsis survivors was a profound revelation.
And observing this massive shift in the bone marrow perfectly correlates with the standard clinical CBCs we review every morning. If the hematopoietic factory redirects all of its primary resources, both energetic and spatial, into producing an endless supply of immature myeloid cells, it must concurrently downregulate other production lines.
That is the principle of hematopoietic competition.
Right.
To fuel the massive energetic demands of emergency myelopoiesis, the bone marrow concurrently and aggressively suppresses lymphopoiesis, the generation of new lymphocytes, and erythropoiesis, the generation of red blood cells. This direct cellular shift within the marrow is the precise biological mechanism driving the profound, unresolving lymphopenia and the persistent, transfusion-dependent anemia that are absolute hallmarks of the CCI phenotype. The marrow is literally starving the adaptive immune system to maintain this dysfunctional innate response.
But if the evolutionary purpose of rapidly releasing these myeloid cells is to aggressively clear the bacterial threat or the necrotic tissue, why do these patients suffer from continuous nosocomial infections? The myeloid expansion isn't helping them clear the ventilator-associated pneumonia, is it?
This highlights the molecular sabotage inherent in the MDSC phenotype. Because they are released in an immature state, they are grossly incompetent at their primary defensive roles.
They just don't work.
They are exceptionally poor phagocytes, incapable of effectively engulfing and destroying secondary bacterial pathogens. Furthermore, they are highly defective antigen-presenting cells. They lack the mature surface receptors required to present processed antigens to T cells, preventing the initiation of a targeted adaptive immune response. But their pathology extends far beyond mere incompetence. They are actively and potently immunosuppressive.
The mechanisms by which they suppress the adaptive immune system are incredibly targeted. Let's break down how they actively paralyze the T cell populations.
The suppression occurs via multiple overlapping molecular pathways. First, MDSCs massively upregulate the expression of the enzyme arginase 1.
Arginase 1.
Yes, arginase 1 rapidly depletes the local tissue microenvironment of the essential amino acid L-arginine. Cytotoxic T cells absolutely require L-arginine for the expression of the CD3 zeta chain, which is essential for T cell receptor signaling and cellular proliferation. By literally starving the microenvironment of arginine, MDSCs render the T cells completely anergic.
That's incredible.
Second, MDSCs secrete high concentrations of IL-10, a dominant immunosuppressive cytokine that further blunts macrophage and T cell activation. Third, they highly express PD-L1 on their cell surface, directly inducing exhaustion and apoptosis in any interacting T cells.
And beyond arginine depletion and checkpoint inhibition, there is the mechanism of nitrosylation, which physically blinds the adaptive immune system.
Yes, the production of reactive nitrogen species. NDSCs generate high levels of peroxynitrite, which chemically alters the surrounding proteins. Specifically, they nitrosylate the major histocompatibility complex, or MHC molecules, on the surface of functional antigen-presenting cells.
And what does that do to the MHC?
This chemical alteration physically distorts the MHC binding cleft, preventing it from correctly interacting with the T cell receptor. The targeted T cells are literally physically blinded to the presence of secondary pathogens.
So we have an adaptive immune system that is starved, exhausted, and physically blinded. But while the MDSCs are executing this profound immunosuppression, they are simultaneously sustaining the catabolic drive.
Exactly. While they're shutting down the targeted T cell response, these immature MDSCs are continuously releasing a steady stream of nonspecific inflammatory mediators, specifically nitric oxide, reactive oxygen species, and tumor necrosis factor.
So they're suppressing targeted immunity but keeping the general inflammation going.
Yes. This dual functionality, actively suppressing targeted cellular immunity while simultaneously maintaining a highly toxic, low-grade inflammatory bath, is the exact cellular engine driving the relentless skeletal muscle catabolism and cachexia defining the PICS trajectory.
The SCRC investigators tracked the circulating levels of these MDSCs in the P50 cohort, and they identified a highly specific temporal shift in their function. They defined this as the day 7 therapeutic window.
The transcriptomic tracking revealed that MDSC populations rapidly expand immediately following the initial severe sepsis or trauma insult and remain persistently elevated out to 28 days.
And what were the clinical correlations with that?
The clinical correlations were stark. Early massive expansion correlated directly with early mortality. However, persistent sustained elevation was a powerful independent predictor for prolonged ICU length of stay, recurrent nosocomial infections, and a highly predictive marker for poor post-discharge disposition. But the critical breakthrough regarding their therapeutic vulnerability centered on day 7.
Because the phenotype and transcriptomic profile of the MDSCs fundamentally alter at that 1-week mark, right?
It is a distinct phenotypic shift. MDSCs isolated from patients prior to day 7 were highly immature, but functional assays demonstrated they were not yet potently immunosuppressive.
Okay.
However, MDSCs harvested from those exact same patients after day 7 had undergone a distinct transcriptomic evolution. They transitioned into highly potent suppressor cells. Post-day 7, MDSCs aggressively shut down T-cell proliferative responses in vitro and actively blocked the production of targeted pro-inflammatory cytokines necessary for fighting secondary infections.
This raises an important question, though. I mean, if we have mapped the exact timeline of the bone marrow's response, and we know exactly when the cellular profile shifts from a desperate innate defense mechanism into a lethal immunosuppressive lock at day 7, does that provide a window for specific intervention?
That day 7 shift establishes the theoretical foundation for the next massive frontier in surgical critical care, which is targeted immunotherapy.
Immunotherapy in the ICU.
Exactly. For over a decade, the field of oncology has invested heavily in developing pharmaceutical agents designed to modulate, deplete, or force the maturation of MDSTs to break the immunosuppressive shield of solid tumors and achieve durable survival. The future of trauma and surgical critical care will inevitably involve adapting the oncologist's pharmacopoeia.
The implication is that rather than simply titrating vasopressors and adjusting PEEP, the intensivist will be utilizing targeted immunomodulators around day 5 or 6 to actively reprogram the hematopoietic stem cells, arrest the emergency myelopoiesis, and rescue the adaptive immune system before the day 7 transcriptomic shift locks the patient into PICS.
That represents the ultimate goal: Because our current reality is that our incredible success with early evidence-based guidelines, damage control hemostasis, and optimized initial resuscitation has inadvertently birthed this highly lethal, chronically disabling PICS-CCI phenotype.
We saved them, but we created a new problem.
We must discard the outdated sequential SIRS and CARS paradigm. We have to recognize the reality of the simultaneous genomic storm and acknowledge that the bone marrow is the ultimate driver of this prolonged disease state.
We have traced the evolutionary arc of our own specialty today, from the 1970s era where drain the pus was the sole strategy against rapidly fatal MOF, through the iatrogenic epidemics of DO2 optimization and massive crystalloid resuscitation, all the way to the modern clinical reality of the chronic critical illness trajectory.
It's been a massive journey.
You, the surgical critical care community, have effectively conquered the immediate mechanical threats of exsanguination and early shock. But conquering the mechanical crisis has forced us to confront a highly uncomfortable biological truth.
The truth is that utilizing advanced life support to simply maintain cardiac output and alveolar oxygenation through the first 48 hours can no longer serve as the sole metric of a successful surgical rescue. Not if the consequence of that rescue is a permanently shattered immune system and a relentless catabolic state.
And that leads to a provocative concept I want to leave you with as you prepare for your next shift. Think back to the adrenaline and the highly protocolized mechanical precision of your last massive trauma resuscitation. If our highly advanced, perfectly executed interventions are successfully saving patients from the immediate threat of hemorrhagic or septic shock, only to lock their hematopoietic pathways into a state of continuous emergency myopoiesis.
A biological state that guarantees severe physical frailty, continuous muscle cannibalism, and a 40% mortality rate while lingering in a skilled nursing facility 12 months later.
Exactly. Do we need to fundamentally redefine the parameters of what a successful rescue actually entails in modern surgery? Are we truly saving a life, or have our technological advancements merely allowed us to shift the timeline and the location of their mortality from the trauma bay to a long-term acute care facility? It is the complex, molecular, muddy water that every modern surgeon must now learn to navigate.